And
all righty.
I'll turn it over to you.
All right. I want to welcome everybody to the HPRCT webinar series. Today, we are very fortunate to have Mr. Ed Kline, and he will be presenting on using predictive analysis in managing risk. Prior discussions, we have agreed that we will not go through his extensive credentials because that takes away from content time. And I will just go over a headline for that. Ed is a medical health physicist with experience in management and operations of radiation oncology centers. Ed has over 37 years of experience in these areas of design, startup of new centers, oversight of operations, clinical physics, health physics, and regulatory compliance programs, and fourthly, the management of QA, radiation safety, and risk management programs. A quick question for you, Ed. Does the name Toby Gilk ring a bell with you at all?
Say it again, please.
Toby Gilk.
Yes, Toby Gilk.
He's a friend of mine. He's an architect who builds MRI centers, and he's
Okay.
big in the regulatory side of MRI safety in the U.S.
Got it. No, well, as you know, that's a diagnostic area, and there's just like in health physics, all sorts of silos. But I don't know if I've worked with him. May have met him, but anyway.
Okay. I got off track, and I want to go ahead and now pass the baton to you. And everyone is anxiously awaiting to hear your presentation. Thank you, Ed.
Well, I don't know if they're anxious. Probably waiting, and got a zillion things to get done in their workday. So, well, thanks everybody for attending my talk, and I know we're all busy, and it's the middle of a work day. I'm in Albuquerque a little bit earlier, but everybody's all over the country, it sounds like. So today what I want to do is focus more on the medical side, and I'm going to talk about risk reduction strategies specific to radiation oncology. But the presentation is geared more towards stepping towards predictive analytics in regards to determining what is coming in a process before you know it's coming. But to get to that point, I'm going to talk about the benchmark for validating the process. A lot of companies or individuals come up with great AI type machine learning products and algorithms. And at least in medicine, the biggest issue has been they sound great. Everybody likes the buzzword, but in practice, they're just not productive. They are tremendous amounts of, there's a tremendous amount of research and a lot of publications are coming out, and we will get there, in particular with diagnostic imaging such as X-ray and CT and things like this. But we're far from getting there with this magic pill. So what needs to be done, and at least from our perspective, is that you got to look at what you have now. How are you building on it? Because it's a tool. And if the tool's not utilized, like a book on the shelf, it's not going to be productive, and therefore it's going to fail and not be validated. So it's not going to be valid in a clinical situation, just like in any operational situation. So let me go ahead and start. And if anybody has questions, just let me know, and we'll stop and we can talk. So first of all, these are some of the individuals I'm working with as we're proceeding towards this path of a AI type machine learning process. And some of these entities are heavily into diagnostic imaging, and that's a big theater in regards to artificial intelligence and predicting various outcomes. So the first steps will be, we'll talk briefly about what are the current state of affairs in the risk management theater in healthcare. Then we'll talk about how big is the problem globally from the US and world. Then we're going to kind of quickly go into the details. What exactly are the problems? What types of surveys are out there regarding medical errors? What about radiation oncology specifically, the treatment of cancer using radiation? Where are we with that type of error analysis? Who reports these errors? This is really important because if you don't get people to report the errors, it's again, the book on the shelf looks great, but nobody's reading it. So how do you get people involved in that process? What type of incident learning systems are out there in radiation oncology? What is the overall risk for different players? What are the requirements to say, for example, the regulatory type requirements versus what are some of the financial incentives. So how do you get entities to have buy-in, to participate in something that will cost money and take staff and FTE and time to get an end result or a product from? We'll look at the prototype model that we're developing in regards to this initiative. We'll look at the actual the skin. It's an actual working model in clinics. And then we'll have some case examples of cost. We'll look at what we learned so far from deploying this at a number of centers. And then we're going to look at specifically how can we pull this into an algorithm that's designed to throw up a flag to identify a mistake before it occurs, even in some cases before you even are aware of it, kind of like a bot in the background. So the current state of affairs is this. 1999 historically was the benchmark, with the Institute of Medicine publication up to close to 100,000 people that die each year in U.S. hospitals as a result of medical errors. And so this was the initial report in healthcare that was the major eye-opening publication, quite in-depth, very credible. And then they analyzed what were the areas where these deaths were occurring, and they were trying to express them in other risk and compare with other risk areas such as road accidents, breast cancer, and AIDS combined. So this was a big deal. It was a big wake-up call. So moving forward through lots of other initiatives and legislation, where are we today in global healthcare? So in the US, we have about 3 to 4% of all patients have some sort of adverse event. So an adverse event is something that's measurable, deterministic, that alters the anticipated outcome of the healthcare process. In that regard, how does this all relate to other risk? So if we were to look at ICU patients and they have 2 errors per day, this translates to a 99% type level of proficiency. It sounds great, but if we take it 0.9% higher in performance and we compare that to the airline and banking industries, this equates to 2 dangerous landings per day or 32,000 checks deducted from the wrong account per hour. So, you know, the percentages don't speak to the significance. And then, you know, we'll talk a little bit about how do we assess significance, but a high number doesn't mean you're doing great. Today, the Society of Actuaries, which are experts in life insurance, health insurance, and they're the ones that define things like what are your medical rates and et cetera. They look at what their results show, and they estimate 6.3 million injuries and deaths from adverse events per year. So the total estimated impact is about 20 billion per year in the cost of treating injuries, lifetime wages loss, and the disability and death. So they get their data from 3 different areas, and they look at claims data, for example, and in healthcare, everything that's done is billed to either a private insurance carrier or Medicare. Medicare is your government, and we pay taxes to pay for that. So claims data is where they extract a fair amount of this data, and they show that about 17 billion per year is associated with additional medical costs from medical mistakes. Going further, they look at liability costs, and it's this includes defensive medicine, testing that's done to ensure that all avenues and venues have been explored. Some may be unnecessary, but to demonstrate due diligence by the physician or administering individual in that process. So they expect that estimated to be 55.6 billion in 2008. And so the overall impact today is about $1 trillion in lost human potential and contributions. So $1 trillion is a lot of money, and their estimates are 10 times higher than the Institute of Medicine basis of a quality adjusted life years due to medical mistakes. So today we're 10 times higher than what we thought back in 1999. So from the perspective of healthcare, how big is the problem? So radiation oncology, from a global perspective, will, as far as incidence, 1 in every 2 men will get cancer worldwide, if not more in underdeveloped countries. But in the US, 1 in 2 men will get cancer, and 1 in 3 women will get cancer in their lifetime. And this does not include skin cancer. This is excluding that type of cancer. But the new cases are projected to be 80% higher up to year 2030 in low-income countries, 40% higher in high-income countries. The market in radiotherapy will be about $12 billion by 2027. So there's a lot of technology being created and things done to treat cancer. So in the US, we have about 3,000 radiation oncology centers that use high energy radiation in the forms of either seal sources, forms of linear accelerator, particle accelerators, or radioactive material, whether in aqueous or sealed source form for treatment of cancer. So about half these patients will get radiation therapy. The other half will get chemotherapy, gene type treatments, and various other modalities. So these costs, based on this study, are about $173 billion in 2020. So we have a pretty good feel for the cost. So then why is this so expensive? Well, it's mainly because the complexity in the process is huge. So if you get cancer treatment, just in an average clinic, there's roughly around 212 steps that are commenced and extended through the entire treatment process for any one individual. And sometimes there are more. So you have easily 212 chances in some areas, and even more, depending on, these are main categories of making a mistake. So the complexity to treat a very precise area of a tumor and the level of precision is huge. And we're talking millimeters, and we're talking even sometimes less than millimeters, depending on what you're trying to treat. So you have all these specialized activities, all these different individuals, which have different anatomy, different morphology, different pathology, different everything that you're customizing. So you can see it's not a machine where you just do one thing and it works for everybody. You have very specific treatment plans generated on each patient. So with this come a lot of subsystems. The trend is to buy treatment devices that are complex and integrated, but it's not always the case, because with multiple vendors such as CT, MRI that we just talked about, PET, X-ray, ultrasound, that's just imaging that feeds into the radiation oncology machine, which is in Emr Systems, which is what they call record and verify systems. It goes on and on. So there's all sorts of different technologies. Some communicate directly, some don't communicate directly. And then you have all the key actors that are involved in the treatment. The computer systems are connected, but not in all cases are they digitally connected. And as I mentioned, that causes manual activities to occur, and even paper and spreadsheets is often used to ensure things are done timely. Barriers continue to exist in radiation oncology. Open reporting of mistakes is still not at the level it needs to be. The local systems typically are not adequate to investigate the incident. What are the contributory factors? And then putting in corrective actions that actually are short-term and long-term that are lasting. So in general, even though there's been a tremendous effort, there's been improvement, we're far from getting to the point where we have a high reliability type process that can compare with other industries. And there are reasons for that, and we'll talk about it. The scale of the radiation market makes it a key area for this type of proactive management approach. The problem is the complexity, and the problem is the data. And without data that's discrete and deep, then it's difficult to create algorithms that can cause a cause and effect type predictable model. So the key is to get the data. And once you get the data, you're the king. You now control how that algorithm will be developed, how fast, and more importantly, how credible. Does it work? Is it predictable? Or is it like a 1 in 10 chance it's going to predict versus a 1 in 2? So these errors that do occur, they propagate. So if you miss them, they go downstream. Then the question is, how fast can you find them before they cause a negative outcome, whether it be a regulatory outcome that's negative or a clinical outcome that's negative. So what did the surveys of medical errors show today? The good news is 6 in 10 Americans have not encountered a medical error. The bad news is the remaining 4 in 10 have experienced a medical error, personally or in someone else's care or both. That's a high number. So not many people want to go into a hospital thinking, wow, I got a 4 in 10 chance I'm going to have a medical error. But that's how high mistakes are occurring. The next survey done was where do these errors occur? What are the main contributory factors? And the main factors are inattention to detail, lack of attention in what you're doing. There are all sorts of reasons why that lack of attention occurs, but overall in the survey, it appears inattention to what is happening in the process. So now we're going deeper into what are the radiation oncology errors and what specifically are their reasons. So most of the data that we have out there in our literature in radiation oncology shows that up to 4.7% of patients undergoing a radiation therapy treatment have some operational clinical shortcoming. Roughly about 100 to 500 patients have some sort of harm annually in the US and worldwide. So this corresponds to about 6 in 10 serious events per million treatments. And some of these lead to death. So that's pretty much what we have going on at this point. How do we compare with other HROs? Well, not that well. We talked about the commercial aviation experience, and you can see from here, there are 15 accidents per year, 0.1 accidents per million commercial flights. It's quite good. Nuclear power plants, very good job too. 31 fatalities between 69 and 2000. And then we have unplanned automatic reactor safety events per year across the globe of about 0.75 between 2004 and 2007. So the estimated probability is quite low for a accident per reactor year. This is quite a bit better than healthcare. So how do we compare within our field of medicine? It's kind of mixed. Anesthesiology was a disaster years ago. They're doing great now. And they took upon themselves how to figure out how to reduce mistakes before any federal agencies came in and said, we're going to make rules to make you reduce your mistakes. But in Medicare, which is your insurance beneficiary, of which a lot of people will be on Medicare, it's not doing that well. And we have numbers of patients that have adverse events. And then, 6,000 patients per million have serious reportable. And a number of these are due to medication errors in surgery or other procedures. So in radiation oncology, the experts believe that accidents are chronically underreported, and some states in the US don't have any reporting requirements. And this is in part because the federal agencies only regulate byproduct material, and the states regulate byproduct machine-produced radioactive material and X-ray produced radiation. So their oversight is more complex, but a lot of the states are not funded properly, and their legislation has not looked at reporting requirements because they can't be supported, and therefore they don't know how many accidents are going unreported, but it's speculated a fair amount. So who reports the radiation oncology mistakes? This is important because in any industry, you have to know who is contributing towards your database of mistakes, and then who is in a position to more likely find the mistakes. So in this case, the World Health Organization reports that from radiation oncology treatment incidences, the number of mistakes are primarily found by what they call the radiation therapist, which is your technician that operates the linear accelerator at the treatment unit. And you can see the green, not the green, but the somewhat bluish bar is much higher than the next person, the medical physicist below it, and then third is your radiation oncologist. And this makes sense because they see patients through an ongoing treatment process that can be up to 45 different treatments over the course of their process. So they're going to see that same patient 6 to 7 weeks, 5 days a week, and you get to recognize them, but you're going to recognize the process, and you're going to be the one that pretty much hits the button that delivers the radiation in most cases. And so they're doing the final checks. So it's unfortunate that a lot of these errors are either found at that point, which should have been found upstream, or the therapist is more diligent in finding it than the medical physicist and radiation oncologist. So it leads a lot of questions into, well, what is everybody doing? Who is doing what? To what degree? Do they have the time? Do they have the expertise? But that leads down to another area of how deep your data is that you collect regarding mistakes. And then you can ascertain from there, what are people's roles? How well are they doing them? You can look at the workflow. How well is that working for the key actors? So anyway, you can get a lot out of the information if you have it. Who reports errors? Also from the AAPM, which is a professional association of ours, and that of another one called Royals, which is more of the vehicle used through another professional organization to report errors. The cumulative error event discovery process shows that most errors are found by the radiation therapists and physicists. So here it replicates similar to what they're finding in the worldwide similar database collection. So if we survey radiation therapists on their comfort level, the people which we know are reporting most of the mistakes, 29% fear reprimand as a result of reporting the mistake. They're worried they're going to get either some punitive action is going to be taken, or they'll be yelled at. So 1/3 of the most highest reporting people are not reporting because they're worried about their role and the management's treating of their role once they find a mistake. So then what are the perceptions of these individuals? And so this survey was talking about their reporting comfort, and they talked about patient safety culture, which is a huge issue in the various industries, and like we talked about, the nuclear industry. And so the hospital level dimensions measuring it are average. There's average commitment, and nearly 10% were afraid to ask a question, either most of the time or always. So then,
Ed,
yes,
can I interject a question before it gets out of this section?
Mm-hmm. Sure.
Jessica is asking, is this fear due to a delay in process resulting in additional costs?
In regards to the reporting, why the therapists are not reporting or why they are reporting?
Yes, why they, the first one.
Okay, why they aren't reporting is that in part, it very well is a result of the number of individuals that are operating the machines and the volume of the patients they're treating. So the crux in private industry is that you need to get the patient treated, and then, oh yeah, we want to make certain it's safe. And that's unfortunate. It's not across the boards everywhere. There's some very good institutions that do a great job and do a tremendous amount of patient safety. However, you do have the need to get the patient treated. So therefore, you have limited resources. They don't have often one person that all they do is check things. They have possibly a person that does some of the checking, possibly the group as a whole does other checks. And so from a business perspective, the question is, what is adequate staffing in order to get the job done and ensure patient safety? So for sure, some of that outcome is based on the fact that it costs money from the management side to pay people to do the reporting that takes more time, which takes away from the efficiency of their staffing model.
Okay,
so
thank you.
I hope that answered it.
Thank you, Ed.
And not in all cases, but in some. As far as hospital incident reporting systems, the rates are high. Most hospital incident reporting systems, they don't capture most harm. And the reason why is that they're broad-based enterprise solutions. They're software platforms which are designed to deal with every department. So let's say you're in a department called urology and you're in a department called diagnostic radiology. I would think the issues they find are entirely different. So then is the platform easy to use, or is it just some narrative that you write in a text description of when you have a mistake? if you're going to do that, then you end up with more issues with recognition of key features of that text to make it useful in trying to extract that data for more meaningful use and analysis later. The other part is that what happens at the higher levels are that the administrative individuals, let's say your patient safety officers that they have in hospitals, a little bit like your radiation safety officer, they look at these, but they're looking at them from all angles, from all different modalities of treatments in a hospital. They can't be experts in all these modalities. So knowing the significance of each event, understanding the action plan may be presented and the level of detail, that presents a challenge. So the best way is to decentralize these processes and bring it down to the level, the working level, where the individuals that are working in that have their tools to identify those mistakes, then put them in some sort of format that's understandable at a higher level to make a substantial change in their favor if they need to fix the mistake, which is usually either staffing or financial or time. So anyway, the systems are not really that good. They are good in the sense of a big picture, but they're not good at drilling down. So then what are the various reporting systems that are out there? Here they are in radiation oncology. The biggest one is the top one. It's called the Radiation Oncology Incident Learning System. All these systems are voluntary. There are some legal documents you have to sign in some of them to ensure that you're aware that that data is going to be scrubbed, but could be used for reporting of various metrics, and the government wants to see those metrics. So there is some of that that has to be done, but they are all voluntary. They're all over the world, and some are quite nice. They have a lot of detail. And so a lot of the data that we collect comes from these multitudes of these systems. So where is the actual risk in the total scheme in radiation oncology? We talked earlier about how inattention to detail was overall the big one in healthcare. Well, based on this report, which comes from the physicist professional societies called TG100, it appears to be human failure, which is a little more different, but this takes into account inattention to detail, just having a bad day, human interactions, various types of mistakes made that are not so much a software type event or a hard-coded hardware type event, like a device failure. So that's number one. Then number two is standardization. In healthcare, we have everybody somewhat doing different things. They're trying to become more standardized, and we'll talk about that. So in regards to risk with EMR systems, EMR, electronic medical record systems, have increased since 2009 from 1% to 90%, which is very good. The problem is that if you have a programmatic systemic issue, it's going to propagate downstream. So now you have issues regarding system design technology, and user-related issues. So these will create incorrect information related to mistakes by entering it incorrectly. The interface may not be clear and clean, or you misunderstood it. Often copying and pasting. In our industry, there are like lots of documents that are used on EMR platforms, which are called dynamic documents. And these documents are somewhat dynamic, but you also can cut and paste in these documents. And that can cause a cutting and pasting of one set of information into the other that's incorrect. Another big one is EHR conversion. With all this technology, when you put different EHR, electronic health record systems together, and sometimes you have to convert databases, it's a very complex process of various import-export filters, DICOM images, DICOM formats that have to match up with the proper patient and with the technology and with the linear accelerator. It all has to be done, and it takes quite a bit of effort. So you're going to have these conversion issues and then other mistakes and on and on. So in regards to doctors, they're key players in the field because they manage the overall treatment. So here's a probability of malpractice type bar representation, showing that on the bottom, if you look at the top number, 40 through 44, 45 to 49, as we go left to right, that's the age of the individual, and below it's the years of experience. So if you get to the age of let's say 65 to 69, and you have 35 to 39 years of experience, you can see the probability of a malpractice suit raises to about 15%. So you can see how it dips and goes up, but this is real because this drives up healthcare costs, and this causes concerns amongst the physicians, and then that drives up defensive medicine and on and on. So the next step is what's required and how do we get people to buy in from the framework of what do you have to do by regulation and what would we like you to receive as a bonus for doing it right. So in healthcare in 2017, they had a thing called the Patient Protection and Affordable Care Act. In this, they put together one requirement that said you must have a patient safety evaluation system where the hospital looks at risk and it quantifies and qualifies, and based on evidence that's presented in regards to real empirical data, you look at correcting these issues, managing it, and analyzing these events to prevent all preventable harm. So you have to have this, and the way they do it is that Medicare will come in to the hospital and audit them. And then if the hospital doesn't have these systems, they will threaten to take away their Medicare contract, and they no longer get money to pay for Medicare insurance to pay for their services. But it's only as good as the level of the audits and whether or not the risk management system covers adequately the different areas in the hospital. An incentive they came up with was, well, why don't we put in a regulation that says we'll have the ability of hospitals and cancer centers and all of healthcare to get a bonus if you do a bunch of performance metrics properly. So in the scheme, they put together a lot of different criteria that you pick from 4 major categories, but you can receive up to 9% credit on doing these type of metrics. And they do this credit based on what they call Medicare Part B, which are physician fee services. So it could be a lot of money. The downside is that if you don't meet these metrics and you're required to do them, you're going to get subtracted up to 9% out of your Medicare reimbursement. So it's a budget neutral type rule where it's a plus or minus, and it pays for itself by penalties or bonuses. So then this program called MIPS goes further, but overall the risk management program, if you put one in, can give you 15% of a total score. And that's how you're able to get money and make money if you demonstrate you're meeting these criteria. And that can be substantial in regards to large institutions and go into the hundreds of millions of dollars in some large entities. So now it's heading towards one more model, and this one's going to be a mandatory model, not voluntary. And they now say that 40% of all entities will have to now follow standards, like particular standards on how they treat patients. And if you don't, then there'll be a penalty phase and a reimbursement bonus if you do. So that's now in somewhat of an experimental stage, deployed in 40% of zip codes throughout the US. So now we're going to look at a prototype model of an error reduction program. So this is an actual program that's being used clinically. It's been used in about 10 centers, and it's used in part to collect data to feed this idea of an algorithm. So the process in regards to the entire process in radiotherapy, so we have a process of a process is here. You can see from left to right, you see a patient coming in a department all the way through the different stages of how they're evaluated, how the computer does what we call a treatment plan, how the physician prescribes, the QA, the physics, and then finally the treatment. So there are 3 bottom checks here. One's done by the radiation oncologist, one's done by the therapist, and one's done by a global group of a team. In looking at how AI can do this better, this process alone is subject to human error, and it's an error remediation activities productivity killer. It takes time. And what you want is a tool that can flag things to ask you, could this be a mistake? Could it not be? Not tell you it is, but make it the judgment call in your hands, but at least flag it so it's unbeknownst. If it's unbeknownst, you find it, or if it is beknownst, you can analyze it quicker. So the idea of this error propagation, the ideal model, and maybe the best way to do this, I'll see if I can do this, is by using a pen. Okay, on the very top up here, let's see if we see it. I don't know if I can get it. I don't think I can get it in there. This may not work. So if you look on the very top, you're going to see 7.0. This is an error generated. And then you see at the bottom, 3.73, this is an error caught. So this is a study that shows in this one category called pre-visit, that's where the patient comes in to be reviewed by the physician and nurse for their treatment. They had 7 errors and they only caught 3.7. But then what happened to the remaining errors? Well, they got through the system. And if you look on the far left, it's 3.27. So then it goes to the next category, patient assessment. If you look there, 17 errors were generated, 14.8 got caught, 5.44 got through. So if you move on downstream through all the different steps, the 212 steps, you reach the patient at 0.27. So that's the number of mistakes getting through to your patient, okay, per each patient, right? About 25% if you break it out per patient. So then the idea of this propagation model would be that when you look at these areas, let's say these are examples where there are mistakes, you're able to break the major categories of where they occurred down, subdivide them, and then divide them further into where are the mistakes occurring to build this pyramid effect of where is our root cause analysis going to take us. So in regards to the overall safety of the patient, the key things that healthcare organizations have to understand and do in some cases are they're under a lot of stress because you have more cancer incidents, you have more cutbacks on Medicare and reimbursement on and on. So you have safety level 1 that should look at causal events, which are tracking and trending, but then you want this tool to go forward with the workers. The idea here is not to overemphasize zero harm. These goals of 0 mistakes cannot be achieved. However, you have to reduce the quantity and quality of the larger mistakes and examine and adapt and examine your failures to prevent the larger mistakes from going down. But all errors in every aspect are almost impossible to reduce. You have to attack this based on what staffing, what individuals you have, and you got to preclude the bigger systematic progressive errors that can hurt you from occurring. So how do we do this? The model we came up with is called SOTERO. Now, SOTER is this Greek spirit meant to ensure safety, preservation, and deliverance from harm. So that's where the name came from. So the whole idea here is to identify risk, you list, measure, and rank. Then you look at strategies to manage the risk. You can reduce it, you can retain it, or you can transfer the risk. Then you implement a risk management strategy, and then you automate as best you can the effectiveness of solutions. Then you come right back and remeasure the solutions to see how well they work. So in this data framework for this SOTERO model, we have it broken up into the left pre-treatment errors and to the right post-treatment errors. So the way it works is the end user puts in these mistakes, and we'll show you that screen. And then in the pre-treatment errors on the left, we have categories, subcategories, and attributes. And these break down examples of mistakes that they could encounter based on what area in the pre-treatment, before the radiation is delivered area, could occur. Then we have in the middle radiation safety and QA. Since radiation safety and QA play a part in the entire process from either quality or regulatory and safety, these should be included also. So they have an effect sometimes on the patient, sometimes not. In most cases, radiation safety does not affect the patient. It's going to affect the workers, the institution. Quality assurance, sometimes if the quality of the treatment checks are not done properly, but the quality assurance could be machine related. It could be miscalibration, wrong radiation dosage given, the analysis of the dosage was incorrect, what was intended was not delivered. So then we end up with post-treatment. And these are the ones which get through the various checks. They got missed and they went downstream, eventually got found. So these are the ones you don't want to have happen because they're the ones that are more significant. You didn't catch them before the treatment, it's less significant. You catch it after, it's more. So that's the data collection frameworks. So the workflow is you want to monitor areas in your clinical process. You want to identify and track mistakes. You want a root cause analysis type methodology. And then what do you do once you find the mistake? What's your roadmap? If we have a dose issue, we have to recalculate radiation dose, we have that. And then you tie this to procedures so that when you have a mistake, there is a push to proceduralize the corrective action. So the program is designed to drive you in that direction. And then you have a approval review of each mistake. Is it credible? Did the mistake reflect accurately what happened? And am I aware as a responsible party that this needs to get fixed? And who's in the fixed chain? Then you want to graph and chart it to make it presentable. Templates are necessary. And then using it as an audit compliance tool, you can inverse this and say, we're going to now audit the center based on these categories that we're measuring. And then you want to reference why are certain areas mistakes or not based on recommendations in the professional field or code requirements that are legal and binding, which are federal and state. So here's what the prototype looks like. So this is used in our clinics. This is actually the first screen you'll see, but it's expanded. So there's a task list that is created when there's a mistake found that needs to be addressed by an individual in the clinic, where their area is where the mistake occurred, because they should be the ones that fix it. So in this case, we just have his task menu that pops up in the morning, and it says, you must approve this error at the very middle called energy error. So if you expand it, it speaks in what type of error it is on the left screen, pre or post, what category, what subcategory. It's a custom attribute, which was not on the list of pre-formatted ones. It affected the patient treatment, description, date, time, etc. And then you're able to view it on a larger scale if you hit to the right, the view button, but it also gives you a picture here of who edited what, and then who's in line for the approval. As this thing goes through its process of the pending approval, each individual gets this email format type task. They have to review it, and it has to be approved, disapproved, or not reviewed. So the level of the review in the software is either simple or it's very complex, depending on the significance. So if you were to enter a mistake, these are manually entered at this point. You can pick clinical, radiation safety, and QA. And of these, you select pre or post, pre-treatment before the patient gets radiation, post after, and did it affect the patient treatment? And from here, you can select from a venue of different categories. You can search them, and it can pick through this 212, no, actually more than that, over 1,800 attributes where this mistake needs to be put. And then here you can click it. It tells you why that requirement is there, from a recommendation for accreditation called the ACR. So you have the benchmark why, you're collecting the data, and then it drives you downstream for corrective actions. So we're not going to show the corrective action scheme or process, but we are going to look at just some of the results. Here's just a simple pie chart. It's showing that 40% of the errors were patient documentation related. That meant there were mistakes in documents related to patient treatments. And then you can see it breaks it down to billing as the big error. The third one up top, 15.8% portal images. Those are imaging techniques used to verify the radiation hitting the target. There was some mistake made in that process. And then the next one is treatment delivery. You had a number of treatment delivery mistakes. Some were significant, others were not. Our idea is to look from quarter to quarter. We want to reduce the number of mistakes, and that's the key. If we go further, we're going to see there's more data collection. And if we move this down, we can see the computer treatment planning at the very top had 20 occurrences, and billing was right below it. So there's some simple type, reporting that's allowed. If we look at each category, we have severity levels put in, and we look at risk priority number. So in prospective error analysis techniques, I think most of us are aware of failure mode and effects analysis. Part of that can be indicating the failure points using risk priority numbers. A risk priority number is your ability to look at the likelihood of the occurrence, the severity of the effect, and the lack of detectability, all which are multiplied together to give you this number. So any number, in this case, above 100 is important. And so that's how we quantify somewhat and qualify which mistakes need to be addressed quickly.
Hi, Ed. Can I interject a question on that last slide?
Yes, sir.
Thank you. This is from John Schaefer. With over 1,800 choices, how does the system derive consistent data? How do you control the data selection entry?
Great question. First of all, there's a lot of training. We'll talk about that just done. And so we get people familiar with the categories, and we have a search function that makes it easier. Secondly, it goes downstream through the review process where ultimately there's numbers of people that review it. And some of those are looking at the credibility of using the right category. Thirdly, there's a final review done by the, I guess the facilitator is the term, but basically your quality regulator to ensure the final disposition of this error is correct. What we do find is that sometimes people pick the wrong mistake, or they create a category that was already there. And the category, you don't want to have redundant data collection. So the integrity of the data is important. And so you're hitting an excellent point where if you get garbage in, it's garbage out. Did that answer your question?
Yeah, I think so. And there's an expansion to that. That was also, what if the error is not part of the 1,800 population that's already in the system? So what if they find something that's not included in there?
Well, that's a good one too, because if you look at this table, if you look at, for example, the category called billing to the upper, let's say the upper top one, and then you have a subcategory called codes, and then you have attribute. You see where it says custom attribute SL2. This is a field you can select. If there's not an attribute, you assign it a severity level. In this case, we have custom attribute SL2, and it has a drop down of SL1 through SL5. You can then enter textually what the mistake is that was not in the pre-formatted list. Then we look at the recurrence of those, and then they're fed back to the algorithm, back to the program to create a new category, so that we don't have people creating custom attributes on the fly, and they do have a recurring one that we see often in the database for them to select in the future.
Okay, so there's a pathway to have a custom, at least an inquiry to say that I have something different, and then there's a vetting process before it would be added to the database.
Yes, sir. Exactly.
Okay.
Yep.
Thank you.
Thank you. Good question. Case examples. First of all, how much more time do we have here? We have.
It's 11:20 right now, and you have the floor until noon.
Okay. Got it. 27 minutes. Okay. Case examples. What we did was now we tried to look at who had done any research out there on how much does it cost when you make a mistake. So an institution at Washington University School of Medicine in St. Louis, they did a study, and they found that the total cost for medical mistakes over a year and a quarter was about $451,000, based on the number of events that they recorded, the average time, the hourly rate per employee, over these categories, starting from left to right at the bottom. So then we thought, okay, why don't we do this with the data we collected? So then we took that number and we applied it to the mistakes found in the program that we have deployed at these centers. And if you look on the very left, you see the bar that's red and the bar that's blue. And that's the frequency of errors that are occurring under that category called portal images. The blue means we caught it before imaging. The red means we caught it after imaging. And then you can see the colors as they go through the various categories: registration, patient docs, CT SIM, on and on and on. Then you have billing, quality assurance, and radio safety where it ends. So when we looked at the cost and applied that across this spectrum of mistakes that were caught and measured, they came to $488,000 for 343 mistakes in this one study. So now we have a second study that says there's a lot of money that's going towards errors. We did a third study, different center. So this is one center, this is another center. You'll see the errors are entirely different. This goes to show you standardization is different. Skill sets are different. Where mistakes occur at different centers are different. So in this case, we had a lot of patient documentation errors that are in that very middle, 142 mistakes that occurred after treatment began. And then you move it on down through the others. But the total cost in this case, in regards to what it takes to fix that mistake, is $713,000, almost $714,000. So there's a lot of money that's going forward. If we look at, this is kind of, it's a lot of information here, so I apologize for this slide, but it's trying to demonstrate that if you look at the causal factors and you put in corrective actions and you measure the frequency of mistakes, then you're going to see an increase on mistakes, but a decrease once you put in the corrective action. So these were actual examples from clinics where we had the very far left, upper left, it has causal factor. We had a lot of mistakes in December. It was because it was a brand new center. They had a high volume of patients. There were performance issues. So then the action plans were to increase a third-party support presence on site, put in an incident reporting program, which was this, have various meetings. They hired a new physicist in this case. They got a billing process in place. So then the numbers dropped. And then we go into another area of big data collection. And then that went down. So you do see that the measurable effects can be somewhat categorized as to what was done to fix them. So this is somewhat of a really broad statement of what these mistakes were and what was done to fix them. So as far as the results of some measurements we did with error rates in the entire treatment process, we broke this out from the very top left to right of pre-treatment, post-treatment, and pre and post-treatment. And we looked at 3 centers. In pre-treatment, we have center A, B, and C, the same at post-treatment, and then pre-treatment plus post-treatment. So we looked at 3 centers. And you can see on the far left, the percent of errors per patient, per fraction, and per field. Per patient is individual treated. Per fraction is each radiation delivery. Remember, I mentioned that we had sometimes up to 42 treatments per patient. And then per field, well, each fraction has possibly 7 to 9 fields. We used an average here, I think of I think it was 4 or 5. And so then you have a percentage basis per patient, per fraction, per field. You can look at center A had 37% of all patients had some mistake. Now keep in mind that these mistakes cover everything in the treatment process. It does not, however, include quality assurance, radiation safety, or billing errors. This is treatment only. But 37%, 10% at center B, and then 61% at center C. The good news was these were caught pre-treatment. But if we go to post-treatment, center A has 72% per patient, 25 and 78%. Now, which one of these errors were important? Not all of these were to the level where you have any measurable outcome. Some were very minor errors, some were documentation, some were in between, and some went into significance. So we'll go down deeper in this. But the point is that you look at the literature, it does not replicate this because they speak only in terms of wrong treatment, the radiation delivered, not the mistakes that are cumulative, that go downstream. And it's a large number. So in our model we're building, we're looking at all this. So we're going to segregate out where the mistakes occur in order to then put a prediction at each level where the mistake could probably take place. As far as error rates in the entire treatment delivery, we looked at literature, and the work we did, center A, B, and C, we tried to look at what's out there and published. And you can see that on the per patient basis percentage, center C had 4.21%. Well, that fell within the upper range of what was published under Marks et al. And then you go to per fraction, per field, and on and on. So this is how it looks across other platforms of other data that's out there in the entire treatment delivery only, not radiation safety, not QA, not billing. So that's your numbers right there. So drilling down deeper, how many near misses? We define the near miss as one where you almost treated a patient incorrectly. That would have been a measurable effect, a medical misadministration, okay? One reportable. So one center, we had 2 near misses. We had 4 near misses at center B, and at center C, we had 1. So that's good. This is called a good catch. So we found some important failures, but we caught them before they got to the patient. Let's look at the ones that got through that were reportable. This is kind of difficult in our field. We don't have a lot of literature on it, but on center B, we did have some medical events that occurred. They were a little bit higher than what's reported via the NRC for only radioactive material on a per patient basis, but it was higher. So it was somewhat of a limited study. Center A and C did not have any medical events. That was good news. So on billing, we talk about billing because if you don't get the billing right, your center is not going to be able to survive. And for every mistake made, Medicare does not want to pay you for a mistake, and that's correct. You're paying for a service to have it done properly with high reproducibility. And so Medicare, by law, does not pay for mistakes. And institutions are not supposed to request payment from patients. But the level of mistakes will vary. So they talk in terms of measurable effects on patients as far as reimbursement not being permitted. But anyway, if we look at this on the billing end, which takes a lot of time because every task done has to have some sort of return on investment in healthcare because that's a business. And the top areas are reporting or failure to send proper documentation and valid signatures. And it looked like in Medicare fee-for-service, it was about 7.25% were wrong billings. That's about $29 billion. So these type of mistakes get put back on the insurance companies and end users, so your rates go up. So therefore, it's important you do the billing properly. So billing infractions, we measured that. Center A had 26% of each patient had a billing mistake. Center B, only 5%. Center C, 44%. The good news was these were caught in most cases before they get sent to Medicare because they have these internal billing systems in hospitals. The bad news is they're doing a lot of wrong things. So we got to train and get people more familiar. And this is all done electronically. These billing processes are electronically done by the end user clicking on a particular charge. And then documents have to support why the doctor ordered that charge in order for Medicare to pay the bill. So QA and radiation safety. Center A per patient had 18.8% errors per patient. Center B, 0.78. Center C, 63. Wow. Well, what does this all mean? Well, it depends on the mistake. Some of these were important, some were not. Some were documentation errors. Some were actual failure to do things timely. The checks were not done timely. They went downstream and caused a big rush. That leads to more errors. But it was quite revealing. If you track this, how many mistakes do occur that are tied to these processes? It was interesting for us to see this. What did we learn from all this? Okay, upfront work. How do you get people's buy-in? You want to present a leadership vision. You have to embrace this non-punitive. Safety is important. It's good. It's good to find mistakes, contrary to it's bad. We give training hours through their credentialing so they get credit. They're required to keep this for their license. And you got to have this non-punitive action policy. You cannot blame people. And if you don't get management on board, this system will fail. And that's the biggest problem in healthcare is the failure to acknowledge the fact that people make mistakes. And that's a tough one. Getting started, what do? We put the software in the clinic, we set up super users, we manage and champion the process, and we phase in this whole software so that people understand it. Weekly meetings are conducted, individuals are assigned responsibilities, often for drafting action plans based on what individuals that are busy can't get time to. And then we track the corrective action. The practical implications are that we have quarterly meetings and we demonstrate through pie charts and histograms how well or poor we're doing. And then we send out monthly safety alerts. We support true chains. And if you want buy-in, you stand by the staff at the center. At medical centers, there's a hierarchy just in industry where you're going to have individuals in positions that will not want to accept responsibility for their own mistakes. Moreover, they don't want to admit there are mistakes. And so therefore your staff becomes the victim and they become the ones that will be yelled at. So you have to support them and say, no, you can't do this. You got to support your individuals, which are actually saving the bacon, contrary to what the thought might be. So we set up a reward system. Our thoughts are you pay people. And that sounds weird, but aside from salary, we give them gift cards and Chick-fil-A cards. We give them achievement activity cards. They can be used in places for like gifts. We have performance reviews where in their performance review, we write in, you must participate in this program. It's not optional. If you do, you're going to get more money back in your review. We acknowledge people like rewards. So this really works really well, but it's, again, a little more money you have to spend, but the outcome you derive from this is immense in regards to the money you save. But on the short term, if you don't recognize this spending necessary to achieve that savings, then you'll never be, I think, fully engaged in where you can go. So AI, we're finally at the AI segment. Voluntary incident reporting systems, they believe, identify only 5% of adverse events. They believe AI, experts believe, has the potential to reduce medical errors by 30 to 40%, treatment expenses by as much as 50. That's a huge number. We talked about the $1 trillion, cutting $1 trillion in half. So that's immense if that could be done. So then how is automation to be used in making an algorithm that works? Based on our research and based on literature out there, the training and education process, though it's important, appears to be somewhat least effective when we look at what's happened. Then policies and procedures, which we talked about, are important. They're next least effective. Reminders and checklists work, but they're in the middle. Simplification appears to be immense because in our delivery system, it is so complicated that you have to take special courses to learn the software, and it's constantly changing and they're constantly upgrading, and you're learning on the fly. So make it simple. Then automation kicks in, where you have automation of reading of different machine files. Then finally AI, forcing the function and constraints, interlocks, flagging things that you don't see, allowing software to operate in the background to generate a flag to tell you in the morning when you walk in, hey, we found a problem. Is this correct? And that would be by a bot process that could be automated to work in the background on various failure points in your electronic medical record, linear accelerator system. So automation has shown to reduce problems. Now, I don't totally believe that the lower bottom ones here are not effective. Don't misread, but based on a lot of the literature that they've had centers go in and try to put in these functional interlocks, these appear to remedy a lot of the problems that they're seeing at the more simplification data entry input. So
Ed, can I interject a question, please?
Yes, sir.
Okay, is there a correlation between reporting mistakes and malpractice settlements that can serve as a disincentive for management to adopt this? And this is from Brian Gestring.
Well, that's a good question. Some of these organizations where you voluntarily report to, and some of the softwares have this ability to allow reporting to a patient safety organization. And these are state-run data collection centers. Part of that agreement is that you evoke a non-punitive, you evoke a protection from criminal sanctions or lawsuits because it's privileged and confidential, and therefore it's protected under the quality assurance framework of, I forget the regulation at the federal level. So it protects the data if you're using a vehicle like that. And you put it in a contract with that incident learning system that they will allow this back and forth between patient safety organizations, and patient safety is the government that wants to collect the data. However, there is also some general quality assurance improvement processes that hospitals can evoke for protection. The downside is that if you have a big enough error, let's say somebody gets killed, there is no absolute assurances that you're not going to be in some legal action. The protection is not that strong to protect you if a person were to be killed. So it's a yes and no answer. That's a great question.
Okay, I think what I'm going to do, because Brian has a follow-up to that, I'm going to unmute Brian. Brian, can you unmute yourself? I'm not able to do it from here.
Sorry, I'm not sure. Is it working now?
Yeah, Brian, you're on.
I'll put my face in there too, although it's never helped any argument. No, I was just curious because one of the things I'm always interested in is how to encourage reporting and how to minimize consequences in reporting. So the follow-up question I had is there a safe space like in aviation? And you kind of answered it, that you have kind of a quasi-safe space, but it, depending on the consequence of the error. But those are things I'm just looking to explore in different industries.
Good question, Brian. I guess it would be the same, because I'm a lawyer, would be similar to if a plane crash kills a number of people, there's going to be lawsuits no matter what. And you see that all the time. But I think in near misses, in other areas where you don't have such a huge 100% worst case outcome, there is protection, and it is granted. And the courts do recognize this. The other vehicle is that if you self-identify mistakes before a inspector or outside individual finds them, let's say some review done by independent auditor, then as you probably know, the NRC will give you an incentive and credit, just call it self-identified, and will not escalate that. So therefore it may not be defined as a violation, or if it is, it's mitigated. And so that occurs in radiation oncology and other in diagnostic imaging, where mistakes are made, but they're reported, and it dramatically reduces things like civil penalty and exposure to the media, which is mandated.
And similar in aviation, if you're an air traffic controller and you make a mistake and you report that mistake, even if it's seconds before a plane crashes, you're essentially immune. So they give you a mechanism to report it. So again, I'm just interested in creating those safe spaces, creating mechanisms for people to report, to try and encourage that sort of thing. So as I said, I will turn my video off to save everyone from that. And thanks for that.
Thank you, Brian.
It's a really good one. And you're right, we talked about that, and we showed what physicians are fearful of. And the whole thing is a huge machine creating additional costs. So there needs to be a give and take on both ends, but hopefully the way they're going in the incident reporting systems and the legislation, they don't want people to fear they're going to be in a lawsuit and therefore not continue to report problems. That's the overall spirit. I'm not certain how it plays out. In a future AI risk model that we're trying to achieve, we want to develop this system to prevent, mitigate mistakes. The key areas in radiation oncology are what we call the simulation. This is where typically the CT or MRI does the image analysis and sends it to the computer that does now the planning for the treatment delivery of the radiation. And then the QA of that treatment delivery, it's correct before you deliver it, and then the details within the delivery system. Those are three key areas where we can find software to mitigate mistakes. So the idea behind the software would be you predict the high-risk error situations, then you automatically detect these and flag them, and then you let the end user determine, for example, is this the wrong patient? Is this the left side? Is this not the center of the patient in the CT scanner? Is the image result of poor technique? Then as it goes downstream, is the patient what they call registered properly in the planning system, so you know where the center of the patient is in regards to where you're going to reference the radiation dosage? And then if it's not, are those like shifting to different coordinates correct? Are they going in the right direction? You know, are the treatment fields within the proper geometry? Are they off by greater than 2 millimeters? Things like this, just examples. You want to preclude the errors before they occur, clearly. And then value-based medicine is a thing going where in healthcare, there has to be value behind what you're doing. And this is the term the government uses for effectiveness and efficiency. The biggest thing here, and you know, Brian, you're bringing up kind of the question related to this. If we can remove the reprimand fear by automating a process, then you can't point a finger at the person who either made the mistake or found it, right? You remove it. The machine found it. This is the biggest benefit of AI, because that removes this fear of, oh no, you got me, or I'm going to get you. And there have been instances where I've seen individuals use a risk management tool against others for reasons that are like, well, I'm going to get at them. I won't say create a mistake, but they're going to jump on board when they get one and blow it up, and they're going to antagonize and cause friction over a tool designed for goodness. This is number one. And then, of course, you want a high reliability system, and you want to integrate patient safety. So our prototype is looking at process reliability in short term and machine learning in long term. So how do we do this? So from Ehr data towards AI radiation oncology, we've got to collect the data in deep, discrete elements of good data errors examples. Collect that data, and then you want an error propagation model to be created. That's phase one. Then phase two, we're going to move towards the processing of this error. And then we want to keep this mechanism ongoing. So as you collect data, it feeds the database that feeds the algorithm to create the validity of the algorithm decision process. And then ultimately, you drive it towards, is this a mistake or not? Or it is a mistake, you got the wrong patient type thing. Or are you certain you want this patient moved in this particular direction? It looks like the therapist moved it the wrong direction. The images that were not taken before you treated, we're alerting you before they treat, so you don't make the mistake of mistreating by greater than 2 millimeters from the intended radiation field versus the actual radiation field. So that's how Kline would work. Here's an example in step one of this partial SQL database. The software just uses a simple database, but this is just one of around 25 not spreadsheets, but fields of data in that spreadsheet of which we extract information. So we have it broken down into type of errors, when it occurred, who found it, not who made the error, what individuals in their roles, what exactly was the mistake, a descriptor, so we can drill down a little deeper into what the mistake was, and on and on. The step two is that you have to look at doing that in relation to all these steps. So this diagram, there's 6 of these. This is only one that I'm showing because it just demonstrates the number of steps that go into a treatment delivery process. So this process tree matches up with some of the what we call the professional standards of how the process works. But in this case, it drills down. So the yellow is what's out there, and that's normally how things are done. The orange is what's been introduced, and the green are the timeframes between different checks along these boxes that need to be done. So we have this times 5 or 6 to create now an entire process of where the mistake could be found, where the process should have been done correctly, what is your timeline for having a check of that area to ensure there's no mistake, what's optimal, what's worst case, and then we put these timelines into this algorithm so we know when things should have been found and when they were found. So then if we look at a process where we determine where the error occurred and predict where it was found, if we don't know, or if the software allows and they put in the date, which it does ask, the newer software, then we can determine a lot of information. So from what we have here, the step 3 is that we break out these key categories and we break them into checks 1, 2, where did the individual, whether it be physicist, doctor, or therapist, find the mistake at the first check level. So the mistake's made, it's gone downstream in these categories. Did you find it when you should have? And what percentage? And here we have 2.4% of the mistakes occurred, 9.6, actually 2.4 caught them, 9.6 caught them at check 2, and 88 neither caught them. So from that end, we had a lot of mistakes going through the checkpoints. Now, these checkpoints also look at timeliness. If you don't get the job done timely, which will affect the rest of the process, that's a mistake. So this type of process drives us towards drilling down to the next level. And then if we look at the next level, we see category level 1, category level 2, check 1, 2, and neither. So if you look at the neither, in this case of patient documents at this miscellaneous level 2, 100% of these got through. If you look at the next one, 99% of these got through. But if you continue down towards scheduling and registration, a high percentage got caught at check 1 and didn't make it through. So this whole thing is called a statistical error propagation model. So what's going on here is what is a statistical error propagation model? It's in statistics, it's a ordinal regression model. What that means is It's a type of regression analysis used for predicting an ordinal variable, such as a variable whose value exists on an arbitrary scale where only the relative ordering between the different values is significant. And that's what happened here. So then it goes to the next level of flagging variables versus predictor variables. So what this means is that we're creating a hierarchical model using proportional odds logistic regression. In this case, it's going to be in R, which is a programming language, until we get the model tested in clinics. And so this hierarchical model is a model in which the lower levels are sorted under a hierarchy, that's my time, of clusters of data. And then that is analyzed for risk analysis. So step 5, show which errors propagate undetected. Step 6, determine the points of weakness. And then here's the last slide. It shows where the silos of data come into the database. And you can see CT simulation in this example feeds data errors down to the database, treatment planning, record and verify, accelerator, and then radio safety QA. And this will feed this real-time program called Sotero. So anyway, in summary, the culture is important. Risk can be managed at different levels. A systems-based approach is really the key. Our data show that most patients experience an error of some sort in their overall pathways of treatment. We do have an algorithm. It's been validated. It's a test. It's using predictive analytics of high feature combinations. And then hopefully we're going to have a prototype of a highly reliable AI-driven system soon. Thank you. And if you have any questions, you can also email me if we don't have time to go through them now.
Okay, thank you, Ed. And I appreciate your patience for taking questions in the interim, but I wanted to be able to ensure they were associated with the point in the presentation that you made.
For sure. Mm-hmm.
From my standpoint, as a 37-year veteran as an RCA investigator in both the manufacturing and healthcare industries, I'm at the wow stage about the level of depth and the how you cited all of that and the logical flow. That made a lot of sense to me. I have a lot of questions, but this is not about me. Does anyone have any questions for Ed in that presentation? And you can just go ahead and unmute your mics and have Ed answer you directly. Tom?
Yeah, hey Ed, can you go to that slide with the pie chart where it was probably about midway through the presentation? I have a question about that slide.
The one with the human failure portion of the pie?
Yeah, it was, the whole screen was a pie chart. Human error was big, was about a quarter of it.
Right.
Not this one, Tom, it's the other one.
The further back.
Okay. It must, this one?
No, that's
no. It's a very obvious.
Yeah, there you go, right there.
That's it.
So this pie chart, what we're saying is hardware software failure, right? This was the hardware software failure, 9%. What are you saying that this is the cause of the failure that caused harm to the patient?
Let's see, it didn't necessarily cause harm because
it could have caused a billing error is what you're saying.
I'm sorry?
It could have caused a billing error.
Well, actually, now the way this data that they presented, this was only for the treatment delivery process. So you are correct that this is tied to radiation being delivered. And, but all these errors in here, let's say 100% of all these on this pie chart did not all result in a measurable negative outcome on the patient. So in other words, you can make a mistake. You can deliver radiation wrong, but it's still going to be within the so my
question is that, okay, they didn't all cause harm, but my question part B is, so hardware, software failure might have caused harm, might not have. But is this what caused the failure? The software is the source of the failure, and the failure either caused harm or didn't cause harm.
You are correct.
So how is human error, human failure, how is human error the source of the failure. So human error is not the failure, right? It can't be. So human error can't be the cause, right? We know this.
In 9% of these, you're correct. In this case, the hardware software, there was a glitch, a coding error, there was a mechanical issue, correct.
But over in the 35% where it says human failure, 35%, how is human error the cause of the failure? It can't be.
Well, it's a good question. Based on this report, it was just wrong data entry into some parameter that needed to be entered properly that went downstream and delivered treatment to the patient and didn't get caught. That's fundamentally.
But human error can't be a cause, is what I'm saying. It doesn't, I don't understand how human error is a cause. Human error can't be a root cause. We know this.
Well, that could be true. This probably has to be drilled down deeper. What do they define as human failure in their components of that? And you're absolutely correct that it is broadly stated here, but these are human error, inattention to detail, examples of putting in wrong information typically, or not executing the software properly, or using it in a failed fashion, where you utilize, let's say, the software where you think you're doing something, in reality, you're making a mistake.
Well, can I just make a suggestion? It seems like there's just an incredible amount of modeling and resources and brain power being put in to measure these human errors. And that's great, right? But you'll never get rid of the human errors. I mean, what you want to do is you want to move all of these models to finding out why the human errors are being made. And then if you fix the whys, you won't have any human errors to measure anymore.
Actually, a great point. In fact, this data, I talked to one of the manufacturers of the software. So for example, your 9% of these errors, and said, you should be using this to re-engineer your software so it's easier to use so you don't produce human error. And so you're looking at how are you learning from your failures to fix it, to prevent it from recurring. That's just one example. But yeah, you're correct. You're never, as we talked about, the key is zero errors is not going to happen. The key is that you have to quantify where you are, kind of like a financial person looks at your portfolio and you're trying to save money. You got to collect the data to show where the money's going. Then he's going to say, put in these mitigating steps to reduce your loss of money so you can save more money. It's the same thing here. But our objective is not to end up with the nuclear disaster type situation. And based on resources, you got to attack the big stuff. A lot of institutions.
Well, what is the big stuff? Is the big stuff making sure that Medicaid gets billed right? Or is the big stuff making sure that patients don't get harmed?
Well, it's the patients not getting harmed, but the billing process is important because that's a compliance regulatory section that if you bill improperly, Medicare will shut down your center. So then you're not feeding anybody.
You realize that if you're trying to figure out why the billing errors are being, billing errors are being made, you're taking away from figuring out why the patient harm errors are being made. You can't have both. You need to separate.
If I could elaborate on this, because I know where you're both coming from, and the human failure here being left on a category by itself is, I think, is what's getting confusing, because if I was to delve, these are not root causes, any of them. These are cause categories. They're not root causes because they're not actionable by themselves.
Right.
But all of them will have a basis in human contribution, but the human contribution has to be based on reasoning, which is usually embedded in systems in which they're acting on, whether it's policies, procedures, cultural norms, socio-technical factors, but what's driving the decision that they think it's the right thing to do at that time. So I think that
I understand, and I'm going to be quiet because I don't want to take up the time for the other questions, but this slide is very confusing. It says sources of error. Human error is the source of error. And we know that human error can never be a root cause. It just can't.
Right. Correct.
And in fact, a lot of the presentation keeps going back to what we figured out was it was human error, and that's the problem. We need to fix it. You're not going to fix the human errors. I mean, I really like the presentation, and I love this whole topic, and we could go on. I bet you like 8 or 10 of us could sit here for the next 2 hours. And I don't hope I'm not coming across the wrong way, but it really seems like there's too much focus on the error and not enough focus on why is the physician, when he's in there, why is he missing? Why it's right in front of him and he didn't hit it with the laser? Why? You know, if that makes sense. There's more to it.
Your points are valid, Tom. Thank you. John, you have your mic off. Would you like to make a statement?
Yeah, I would. I'm going to switch topics a little bit. When you're looking at errors and how you catch errors, are you monitoring or categorizing how the errors are caught? In other words, the triggers. You know, we did that in the biotech realm where we had reportable event codes. We were monitoring how people were catching the errors and trending those too, and then that helped us develop better algorithms around the CAP process or CAPA process.
Well, and yes, we are. That's a good point, because when we look at the error categories, let's say, for example, we have a QA mistake and it's not related to the patient. It was a check of a process that wasn't done timely. And we have like checks, for example, like the therapists that are at the machine do weekly checks of the patient records to make certain that the data is accurate and correct and timely. And so if they didn't do that check, we know it happened at that step in the check process. Now, why they didn't do it, good question. Why did it get missed? And that's a great question. We don't know.
And reversing that, how did it get caught? In other words, you're seeing things missed, but you're also seeing things caught. Are you trending how they're catching the errors?
Yes, some of these are caught through the initial checks that are done in the process. So we talked about check number 1 and check number 2. That means that we have people that their job in part is to go through that record and verify that those various steps were done at a particular time. And the areas of checks are done based on expertise, like your therapist does one check, your doctor does another, and physicist the other, and they can cross over. Even your front desk.
I guess, but rather than just the checks itself, like what triggered the check? In other words, they're going through and they say, oh, this parameter is outside this tolerance, or, you know, what is causing them to question and say this is an error versus it's not, because they're looking at all, and obviously things are getting through, but some things are getting caught. So if 50% gets through and 50% get caught, if you look at what are they using to catch the error, you might be able to expand it out to catch that other 50% they're not catching. That's where I was trying to go.
Well, the only thing we have are, before we do this program, we have policies, procedures, and training. So in the procedures, they tell you, you must be checking this for these parameters to be verified as correct. And then we measure how well they are, at least verifying that that data entry is correct. Now, why they put in the errors, which is a deeper thing, or why did the errors occur, which is in part kind of what this slide from this professional society put together, then that's that drill down effect of root cause analysis. And in the program, we do look at that, not on all mistakes. It's based on significance. I didn't get to show you, but they do a credible root cause analysis. It's very in-depth. It goes down into about 25 screens of drilling down. And then we have intermediate type severity levels of mistakes that are more, show me from this list of what you believe the corrective action is, and specifically, how do you drill down deeper into a long-term corrective action? Then you have some minor errors, which are just, we collect the data. So there is a logic behind it that I couldn't get too deep into because it would take forever. But you are drilling at failure, at I should say breakpoints in processes that are drilling to the individual. Why did you make that mistake? What happened? Did we not train you properly? You know, sometimes it could be a bad hair day. Sometimes it could be a combination of things. I've made my fair share of mistakes in the clinic, And I've actually had therapists find it. And I'd look at myself like, how did I make that mistake? And part of it was that I was rushed. Part of it was that I just wasn't paying attention. It wasn't anything. I'm trained. I've been to a zillion classes. It's not always that easy, but these are great questions. I appreciate
I guess
the level.
my experience in that area is you look at attention resources and the Wickens information processing model, and that'll help you drive back into the why the mistake was made at this time and it wasn't made 50 other times that the same person did the same thing.
Okay,
Yeah.
I want to thank everybody for your questions and be respectful of the times that we have. I really want to thank Ed, especially for the amount of head down time you put into this presentation and the level of detail. And I think that you have Ed's contact information if you have any questions further. And I want to thank Ed for your time. And I found it to be a fascinating presentation, given I'm in this field and understand the level of depth that you went to. Even though, you know, there's a misnomer of understanding errors versus mistakes and things of that nature. But this human performance is a key part of HPRCT. And I think you hit on a lot of great points on here. So thank you for your time, and thank everyone else for attending. And we appreciate it. We'll see you next month's webinar.
Yes, sir. Thank you, Robert. Thank you, everybody.